Welcome to Your Doctor Wants to Quit, a podcast inspired by the need to save healthcare in America. I am Dr. Joy, a board-certified emergency physician, and I created this podcast to shed light on the challenges our healthcare system is facing through the multiple lenses of doctors, other healthcare professionals, and patients. By listening and working together, I believe we can fix healthcare in America for all of us.
One of the things I struggle with is this fear of missing something. And the adage in emergency medicine is worst first. So we're going to poke and prod and get CT scans, whatever we have to do to make sure it's not that horrible thing. And it's a lot of times overkill, but I don't feel comfortable risking missing something, and I'm not going to get another shot.
You're hearing the voice of Dr. Sierra Bourne, a board-certified emergency physician and chief of staff at Northern Inyo Hospital, a critical access hospital in the rural town of Bishop, California. Dr. Bourne and I did our residency together at University of Arizona Medical Center in Tucson. We were both raised in the same tradition of medicine at a level 1 trauma center in a busy urban area, though after our training, our paths diverged. A decade and a half later, I'm thrilled to reconnect and to get her perspective.
I'm Sierra. I'm an emergency physician, and I work in rural California pretty much for my entire post-training career. So my father's a physician, but when I was a kid, I wanted to be a cartoonist or a veterinarian, marine biologist was definitely up there. But then in high school, I took this anatomy class with an amazing teacher, and I think there were only 7 of us, and 6 of us went into some kind of medicine. So it was pretty impactful, and that kind of propelled me into college as a pre-med right away. My brother became a physician too. My dad, he just retired after 38 years as an anesthesiologist, and he loved it. And so it was pretty inspiring to see him create a life for himself that supported the family and that he really enjoyed and got a lot out of. I went into it thinking that I would do anesthesia, which is what he does, and subsequently what my brother did as well. I did med school at USC, which is an emergency powerhouse. And at that time, and probably still now, a lot of the attendings had relationships with Hollywood, being in LA. And so there was a career day, if you will, at med school. And I walked into the anesthesia one, which is in this little classroom. And the doc, the first thing he said was to the effect of, so in anesthesia, basically you make a lot of money and you don't work hard. At that moment, that was really offensive and terrible to me. Obviously, with some life experience, it doesn't sound as horrific now. But then I went to the ER one, which was in our largest lecture hall, and they dimmed the lights, and they played this very well-edited film. And I didn't know this person, but I still remember it, and I don't know basketball, but there was this college player, Hank Gathers, who was a total star, and he was diagnosed with cardiomyopathy and placed on a beta blocker. And the school actually got an AED at their gym kind of because of his situation. This is obviously before AEDs are prevalent and required in a lot of places, such as gyms. But he weaned himself off the beta blockers because he felt his performance wasn't as good. And he syncopized in what was likely cardiac dysrhythmia during a game, and they filmed it. So we're watching this scene, and you see some athletic trainers kind of running up to him and just putting their hands on him, sitting there. Nobody got the AED. Nobody really checked his pulse or did CPR. And so ultimately he died. And this was Mel Herbert, who obviously has his own emergency educational empire, really. But he was like, you know, it matters to be good at resuscitation. It matters to train in this, and what you do matters. And it's like a rallying war cry, and it was just so awesome. So I was like, I'm going to do emergency medicine. So basically, you start applying your last year to different residencies. I think I did like 15, and I know people were starting to apply to 30 or more. And we still went on in-person interviews at that time. And so you're still in school, you don't have any money, you're flying around the country, it's fun, but you're going broke. And you're touring a bunch of hospitals. It's just a bunch of information overload. But then you take all that information and have a ranking list, and all the programs rank the applicants, and some kind of computer system arranges us in the most sensical. I don't know if it's fair or like exactly how they do it, but they match you together, and it's called the match. And so on one day in March, we got an envelope, opened it. There were tears of joy, there were tears of disappointment. And so it was kind of like this culmination of, here's your future, at least for the foreseeable 3 years. And I don't know, it felt pretty intense. I got my 4th choice, so it was a little disappointing, but I really enjoyed Tucson, where we trained. I think there was a lot of room for human connection and support. And to be honest, that's not something that I've had since, not in my traditional ER work. So that's something that probably every residency tries to cultivate and doesn't always happen. But I think just having that close-knit peer group going through the trenches, if you will, together was super special, and it was a great location.
Dr. Bourne was in the class just 1 year after mine. She joined University of Arizona's emergency medicine residency as I was starting my 2nd year of our 3-year training program. While there, 80% of our shifts were spent at University Medical Center, with more than 40 emergency department beds, a separate pediatric ED, and 7 trauma bays. UMC was and still is the only Level 1 trauma center in all of Southeast Arizona, with more than 3,000 trauma evaluations annually and 65,000 emergency department visits per year overall, making it one of the busiest emergency departments in the entire state.
In Tucson, urban environment, a significant amount of trauma, pretty bad medical conditions, a lot of underserved population who struggle with substance abuse, homelessness, not having access to care. We had a lot of frequent flyers, which is probably any emergency department. And the acuity was pretty high. Having several hospitals in the area, we were the tertiary care center.
After 3 years of residency in a fast-paced university hospital, Dr. Bourne returned to her hometown in the Eastern Sierras to set roots. She accepted a job at the local community hospital where there were significantly fewer resources compared to the Level 1 trauma center where we trained.
I grew up in the same town in which I live and work now, and I always wanted to go back to the community in a smaller town. And I grew up in the mountains. I enjoy skiing, hiking, stuff like that, and went straight into community medicine in a 7-bed ER with about 10,000 patients a year volume, which is small, and it's single coverage. So I'm the only doctor there, like in the middle of the night. I'm literally the only doctor in the whole hospital. And it was crazy. I showed up and most of the doctors were peri-retirement. And, I just came out. I'm like, so, is anyone gonna show me the ropes, or, what kind of mentorship is there here? And pretty much from the first day, I know specifically one of the docs was like, so you just got out of training, you know everything. Why don't you tell us what to do? And I was like, oh, well, I'm not sure that's totally how I feel, but yeah, we'll give it my best, and been trying to do the best with what we have ever since.
Are all of the doctors that work at your hospital board certified in emergency medicine?
Now, yes. Then 12 years ago, no. It's weird to be like an old dog, if you will. We dictated into the phone, rambling, and some poor transcriptionists had to go through it all. In residency, I don't remember that EHR we used at South Campus, but that was kind of horrible. And then when I came out, I had T-sheets where you just like circle and cross out and have this kind of illegible, like handwritten note that gets scanned in, and different variations of EHR. I think I've been through about 5 in the last 12 years at one institution, which is totally demoralizing. We did this big rollout with one which was trying to break into the hospital market and thought we were the right size for it. And it was apparently ridiculously cheap, which bit us in the butt hard because they folded and we had to switch because they weren't going to maintain their platform. So less than 2 years after this huge multi-week, multi-month, hours and hours of training, we had to do it all over again. And that was pretty brutal. Some people retired, honestly. But yeah, now I think there are a lot of efficiencies and it's constantly evolving to try to help us. But the number of clicks, just the amount of stuff on the charting documentation side is pretty overwhelming. And it's not so much the clinical stuff that most of us struggle with. A lot of it is the paperwork side. And I know I stay, like I worked 3 to 11 last night and I left at 12:30, 12:40. And most of that was charting. I got 8 patients in my first 2 hours, which kind of set the tone of not being caught up.
Dr. Bourne is describing a common frustration felt by all physicians, the struggle to balance home life with patient care and to simultaneously shoulder the administrative burden that is only increasing. I asked Dr. Bourne the same question I ask of all the doctors I interview. Despite all the challenges she has experienced in her field, if she could do it over again, would she still pursue a career in emergency medicine?
This one is like, there's hesitation, right? I can't just be like, yes, of course, totally. But I have built this amazing life. Like, I live where I want to live. I have a well-paying job and I'm able to support my family. I feel like it's all been due to medicine and my career, and I'm super grateful for that. But it's been hard, and I've been talking a lot with my cousin who's a 4th-year medical student right now and has decided to go into emergency. And when he talks to me, I have to maybe check myself a little bit because it's been a long few years. I think the struggle of parenting, being the breadwinner, being the woman, in the relationship and the dynamics of that, which is sometimes inevitable, but at least like that pattern, as well as a lot of the stressors of, our work. It's difficult and there's been a lot of burnout. And so I don't want to discourage him, but at the same time, when I was young, I think when I was deciding, my dad was like, you have to work night shifts. And I was like, yeah, no problem. It's fine. Sleep whenever, sleep when I'm dead, something like that. And then, holidays, it's like, yeah, who cares? Like, you can have fun on any day. But as it goes, that can wear you down. And specifically like nights. I mean, making a decision about what you're going to do with your life when you're in your 20s and it relates to sleep is like not good. Because like parenting and getting older, I mean, like so much of your life revolves around trying to get a good night's sleep so you can function. It's so weird. And so, this ER schedule with specifically the night shifts is like pretty much scientifically proven to be shortening my lifespan. I think it's probably less than smoking or something, but it's not good for you. And it just kind of sledgehammers your life every few weeks, So that was something that I didn't necessarily take stock in, because when I was in my 20s, it wasn't a big deal. You just sleep before or later and didn't need that much sleep. I don't know. When I started, I did 50% nights, which is normal. And I know of a couple partnership tracks. So when you get right out of training, you're working your way up the ranks, and it can be 2 years of only nights. I've heard of that, which sounds awful. A little bit predatory, honestly. And then when I got pregnant, at the later part of my pregnancy, my first one, and then while breastfeeding, which I did for over a year, I worked only nights because the pace was slower and because I could reliably pump. And in retrospect, that probably wasn't an amazing situation, but I guess you're kind of jet lagged for your whole life with a newborn anyway, so maybe not not terrible. Doable.
I totally hear you. That was the worst thing about when I first started as a junior partner, and they had all the junior partners essentially work basically every Saturday night shift. And the hardest part about it was I had to sleep on Saturday during the daytime in order to prepare to work at night. And then I would work all night long and be exhausted because also they understaffed Saturday nights. Normally we would have 4 docs at a time on a night shift, but on Saturdays we only had 3 because nobody wanted to work Saturday night shifts, which then made it even that much worse for those of us that were there. And then Sunday, you're exhausted because you had this epic, horrific night shift where there's literally people coding all night long and you're running around like crazy, doing crazy central line procedures and all kinds of things all night long. You get home and you're amped up because it's so intense. It's hard to relax. You eventually get to sleep. And then, your Sunday is completely shot because you sleep during the day to recover. And then by the time Monday morning rolls around, it's like the kids are back to school and you didn't see your children all weekend because you slept all day Saturday, worked all night Saturday night into Sunday, and then slept all day Sunday. And then doing that over and over and over again, I think for me at least, it really had an impact on the quality time that I got to spend with my kids and the relationship that I had with them during that phase when I was working those types of hours. It was really, really hard. It's not just the children that suffer. I think we suffer as moms too, because we want to be there and we can't be. And you have this feeling of being torn apart on the inside, part of your heart with your work, and that's important. But then you're sacrificing your family's needs and that critical bonding time when your kids are little, which is something that you can't get back.
Oh, just boatloads of guilt, really. Yeah. And then feeling like you're failing in all the sections, work, home.
Yeah, it's like
sleep, exercise for sure, eating. Yeah, just fail. Like put all the categories out there and then cross them all out. Medscape just came out with kind of like a burnout assessment, and it was like ER topped the list and females were more likely than men, and my age demographic was the highest, and I was like, oh, I'm like the poster child for burnout. That's interesting. Okay.
The lack of sleep, long hours, missing holidays, and important moments with family all contribute to burnout. But it's also, in large part, the things we are trained not to talk about. It can be really hard when things don't go well, and I think our personalities, the personalities of people that go into this type of profession, we are in it to win it for our patients, and I take on that responsibility.
I really try to appreciate the wins. I think you have to just kind of celebrate when things go well. Unfortunately, that's not, every patient.
The reality is you can do everything perfectly, and there's just some people that by the time they get to you, there's not really anything that you could have done. But even though that's the case, it doesn't feel that way when you have to tell the family or you have to go home and live with the things that you witnessed during your shift.
More than half of emergency nurses and 60% of emergency physicians report high rates of burnout. Studies have correlated these rates of burnout to the high acuity critical cases that healthcare workers in the ED are faced with every day.
Can you imagine if there weren't emergency departments open 24/7? But there's a cost to pay to provide that service, and the cost isn't just financial, it's a human cost in terms of the impact it has on the people that provide those services. And I want to get into this discussion a little bit about how the emergency department is being used in the United States. All the more reason why to take the burden off of the emergency department and to find other more practical and pragmatic ways to get people the care they need, because it doesn't make sense to fill up an emergency department with a waiting room of 40 people, and at least half of those people might be there because they couldn't get a same-day appointment. They have an urgent need that's not necessarily immediately life-threatening, but it can't wait for 6 weeks until they can see their primary care doctor, and they have nowhere else to go. What has that been like in your practice environment in a rural community?
So one of the major differences between us and anywhere urban is that we don't have urgent cares. So a lot of what we see in the ER would be appropriate for that. And that's probably any ER. And yeah, the utilization is not optimal. I think it also reflects the dysfunction of our healthcare system overall. It's difficult to go through things in what you would say the right way. Like if it's a non-emergency, then you're supposed to pick up the phone and make a call and try to get into the clinic or seek out somewhere. You might have to spend a little bit more time discovering, like an urgent care. But there's so many barriers. Like no one answers the phone, you leave a message, nobody gets back to you. They don't have an appointment for 3, 4, 5, 6 weeks. They're not taking new patients. They don't take your insurance, all of those things. So I think there's so many barriers in the rest of medicine that with the ER doors always open, we get a lot of that. People who have nowhere else to go or whose insurance doesn't pay for anything, but apparently our expensive version of care, all of that. It's just, we are the safety net and the rest of the infrastructure is not functioning greatly. So we're just catching more and more and more. And it's not necessarily what we were designed to do or what we should be doing.
Yeah, I think that's a really good point. So what it makes me think about actually is EMTALA, which I think is one of the greatest creations that ever came to be in our healthcare system. And in some ways, it also is sort of sabotaging us in a way. For those who may not be familiar, EMTALA is essentially the federal law that went into place that means that everybody in the whole country, if you show up in an emergency department, it doesn't matter whether you have insurance, it doesn't matter whether you're in network, it doesn't matter whether you can afford to pay a medical bill or not, you're entitled to an emergency medical evaluation. And what that does is it essentially ensures access to care, but only through the emergency department. And so, whereas even like in an urgent care, if you go to an urgent care and they're not in network, or then you're uninsured and you can't afford to pay the self-pay rates or whatever it may be, you can show up in the emergency department and you'll get taken care of, and you're not going to have to swipe your credit card or come up with any money. We're just going to take care of you, which is a beautiful thing. And it's part of why I wanted to go into emergency medicine, because I didn't want to, as an ER doctor, have to turn people away because they couldn't pay. I wanted to just focus on doing the right thing for the patient, taking care of them. And that was really important to me, to not feel like I was torn between the business of medicine and the practice of medicine, and to not have any of those internal conflicts. But I think that was also, to some extent, a young person that's idealistic and slightly naive and not really fully looking at the big picture at the time. Because what ends up happening is, as wonderful as it is that people have access to care, it's sort of like the catch-all that does not create pressure or incentive to find other less expensive, more practical pathways to get access to care outside of the emergency department, which is the most expensive place in the healthcare system to get care. And it's not just about cost either. It's about access for the other people that might need care more urgently. If you have a waiting room that's full of people and some of those people have things that could be life-threatening in the next hour versus life-threatening in the next 72 hours, we have to be able to triage. And if there's not an efficient way to triage people and to get them the care they need in the time frame that's required to meet their needs, then we're not making good use of our resources. So I think that we need to reimagine how we deliver healthcare in the United States. Because again, I am so grateful that EMTALA exists. It meant that I never, ever had to turn someone away that needed something, which was amazing. It's one of the reasons why I love my job. But the consequence of that is, I think, unintended, is that we are just becoming more and more overloaded in the emergency department and becoming really the only safety net that's immediately accessible to people, which is not sustainable, and it's going to just get worse.
Yeah. I think there's one thing that non-medical people would not know. The style in which we give care in the ER is super different than, for example, when you have a primary care and you have a relationship. And one of the things I struggle with is this fear of missing something. And the adage in emergency medicine is worst first. So we're going to poke and prod and get CT scans, whatever we have to do to make sure it's not that horrible thing. And we're going to do it all now. And it's a lot of times overkill, but I don't feel comfortable risking missing something, and I'm not going to get another shot at it. This is the one time I'm going to see you. So I pretty much got to get everything done, get it done now. As opposed to if there's a relationship between the practitioner and the patient, you can start with the basics and you can go from there. And especially if there are features that aren't suggesting that it's life-threatening, you can work through a diagnosis. But I think now more so than ever, we've been trained with our smartphones and in this kind of digital, everything at your fingertips time, that waiting a couple of weeks for something is not something that we want or are prepared to do. And I think a lot of people don't appreciate that there is over-testing. We could be causing harm by unnecessary scans. Even unnecessary lab tests can lead you down these kind of rabbit holes that can seriously cause harm. So I think there's also this mentality that more is better and that everything should be done all the time. And it's actually counterintuitive, but that can be harmful in its own right. And that's not what we should be doing on a regular basis.
I totally hear you on that. And it's also true that although you are ordering everything and in your mind maybe kind of over ordering, there are so many tests that might be required to work up something that's nuanced that aren't even available in the emergency department, that we can't get. We usually only order tests that we can get back within the context of an emergency department visit. And there's some labs that have to be sent out that might not come back for 2 weeks. And we're not supposed to order those because we have no way to follow them up with the patient. Sometimes We feel like we're throwing the kitchen sink at things so that we don't miss something. We don't necessarily even always have all the tools at our fingertips to not miss something. And that same patient might come back to the emergency department 3 or 4 times with abdominal pain and get 3 or 4 CAT scans over the course of a couple of months and still not have been able to get in to see the GI doctor or their primary care to order more specialized tests that would be required to figure out what's going on, which is unfortunate. And that kind of gets into what you're talking about over ordering, because we can only order the things we have on our order list. You know what I mean? And so we just keep ordering those same things over and over again. And the problem might be a lot more complex than what could be figured out in the course of an emergency department visit and require complex coordination of care, which just is not happening very well in our healthcare system. Now I'm on the other side, right? Because I'm functioning as a primary care doctor and I have a private practice. And I fortunately am lucky enough that I know most of the people that work in the local emergency department in my urban area. And so when I have a patient in my office that I think needs to be seen in the emergency department, when I send them there, my colleagues know that I did everything I possibly could as an outpatient, or I wouldn't be sending them there. B, when the patient gets discharged from the emergency department, they know they can just pick up the phone and call my cell phone and give me an update, and I'm going to make sure that patient gets seen the very next day and take that as a warm handoff and make sure that I continue whatever the next steps are that are required. But that is extremely rare. Like, that level of communication and coordination is just not happening. But that's the kind of thing that prevents people from bouncing back to the emergency department and having misdiagnoses and not getting the follow-up. And, it's scary. Being on the other side of that as an emergency physician and not having those contacts in the community to feel comfortable that if I discharge this person into the world and they need XYZ to be done, I'm scared XYZ is never going to get done. And so I feel like I've got to do whatever I can in that moment to safeguard something terrible from happening, because the patient is going back into the world completely untethered with no specific follow-up plan. There's just not a mechanism for that in most healthcare organizations today, which is really sad.
Totally. I mean, I think the barrier to be admitted to the hospital is quite high. And so I think there's a lot of people who, again, don't need or weren't being hospitalized, but just aren't going to get what they should. Even in my community where there's one hospital and the clinic is associated, and so our EHR includes both, and I can look at those notes, which is very handy. I can't tell you how many times, even in that more rare and ideal situation where you were able to get follow-up as an ER doc, which is, again, rare, it just seems like it somehow falls apart more frequently than not.
I mean, you're the chief of staff at a hospital, but you as a single person don't have the ability to affect all of these changes that we need to go into place to make things run more smoothly. It's sort of like the system is set up with the wrong incentives in terms of how the system is set up financially and how reimbursement works. It incentivizes things to be dysfunctional. And it's, I think, really going to take a realignment of the reimbursement model with insurance. Part of the problem is primary care is not compensated well enough to provide the robust staffing resources that it would require to provide on-demand same-day visits. And so to survive as a primary care doctor, you have to stack your patients 10, 15 minutes apart just to make enough money to cover your overhead and all this. And even then, primary care is still a loss leader for most health systems. If you look at it from a kind of callous standpoint of how the money flows, primary care is essentially a feeder into the larger health system for the more expensive procedures and other surgeries and testing and things that get done that reimburse much better than a simple primary care visit. And so unless we're willing to empower primary care to really take the lead and to be the steward of resources, but also to have the financial backing to really do a good job of coordinating care and taking ownership of that, it's not feasible with the current reimbursement model. You don't get paid for calling the GI specialist and having a conversation and then waiting on hold to, get some test approved with the insurance company and then, calling the imaging center and seeing if they can squeeze somebody in. Like, none of that gets compensated, but it all takes time and human resources. So it's tricky, there's a lot of work to be done to make things better.
It does feel like the structure of our country's healthcare system started with money, and what we're doing clinically is like balancing on the top of the house of cards, right? And it really should be the opposite. We spend at least a factor more than most of the other countries, and by measurable standards get worse care. And I think a lot of that has to do with how much of it is happening out of the emergency department and how many balls are getting dropped in between. And yeah, if you want patients to get good care, it might require specialty care, but it should be centered with a primary care who knows that patient has ideally, the connections or the resources and the relationships to make things happen. And how are you supposed to do a job that takes a lot of work and training and caring and time when it doesn't pay? You can't.
It's a commonly accepted phenomenon in large healthcare systems that primary care clinics operate at a loss. The statistics show these losses can range from $100,000 to $500,000 per practice per year, and the cost is simply absorbed by large health systems that are profitable in other areas. Why do these health systems acquire primary care practices that lose money? Because health systems see primary care as the funnel that feeds patients into the hospital for the more complex procedures which create profit. If large health systems own the funnel, they can control downstream revenue. It doesn't take a rocket scientist to see how this can create perverse incentives. Meanwhile, independent primary care practices that are not owned by large health systems can no longer make enough money to stay in business. And because they are small, they have no negotiating power.
Like my husband works in construction and it's time and materials, right? Or a bid. But we're not getting paid for our time or our materials. They're just like, oh, you spent 2 hours. Why don't we call it good? How about a third of your charges? How does that sound? So, and that's pretty common in medicine where the reimbursement doesn't even cover the cost of what it took to see that patient. That's crazy. That's really messed up.
I hear you. And I think one of the many things that is insider knowledge, one of the dark secrets, is that we don't actually control at all what we get paid. I think people think that we do, but we really don't. They see bills go out, and so it's confusing, right? Like you send a bill to the insurance company, and people think that that's what we're deciding to charge. That's not what we're deciding to charge. We just have to fill in the blank with a dollar amount. We have no idea what we're actually going to get paid. And the insurance company can basically pay us per the contract, whatever it's been prearranged that they're going to pay us. We don't necessarily even know what that is all the time because there's so many different codes that get billed, and there's so many different reimbursement amounts that are allowable across so many different insurance companies. So like Aetna might pay $75 for the same service that Blue Shield might pay $100 for, and Anthem might only pay $25 for. And it's the exact same service and the exact same code, and multiply that times so many different insurance companies. I meet with our billing team on a weekly basis, and we're still trying to figure out how to anticipate what we're going to get paid. And it has absolutely nothing to do with what we charged. Literally nothing at all. If we get paid less than what we think we're supposed to get paid, we just have to accept it. We have no negotiating power. We can't do anything about it. And so it is what it is, But you're right. Like in no other business do you agree to do work, then do the work, and then send a bill, and then whoever's supposed to pay, the other company says, I'm actually going to reduce that. I don't like what you are charging me, so I'm actually going to give you a third of that or 25% of that. And then you just accept it, and that's it. And that's just how you do business literally over and over and over again across hundreds of patient visits and hundreds of services. It's pretty wild.
Well, and you haven't even gotten into the fact that they can just straight up deny.
Oh,
you
yeah.
have to fight for anything, right?
They can actually take back the money that they've already paid you after the service has been performed. And we saw this a lot during the pandemic because things got pretty chaotic. For a period of time, there were all these new laws coming into place that were trying to give people access to care when everything was shutting down. And so they made these laws that basically said, you are able to go to any healthcare facility and get a COVID test at the height of the pandemic. And the insurance company is required to pay that fee whether or not the patient is in network with that practice. And so in my practice, our main source of business at the time became COVID testing, because everything else was either A, initially prohibited because we weren't allowed to provide non-emergency services legally because of the shutdown. And then B, we were able to then provide some services, but people were afraid to come into the doctor. And so they were only coming to the doctor if they were afraid that they had COVID. And so that was essentially our sole source of revenue for a period of time. And during that time, all the laws that were coming out were kind of all new, and we were just trying to keep up with what the billing rules were and everything. And so we submitted all of these claims to insurance companies for the COVID testing. And a lot of the times we would get paid, and then a couple months later, they would be like, oh, actually, no, this was an inappropriate payment, and they do a take back. And they'd actually take the money back from us for the service that we already got paid for. And they do that in a way that they essentially hold any further payment of claims from that insurance company. So you don't start getting paid again until you have paid back all the money they arbitrarily took back. It was
totally insane. Yeah.
It was so hard. And there we are, like, in our PPE, making masks because there's not enough masks. You know what I mean? And people are like desperate, showing up in the parking lot. Some people really sick, triaging them to the hospital and all this stuff. And it's like, you don't even know if you're going to get paid for any of that, but you just keep showing up because what else are you going to do?
Yeah. Well, and that in particular was kind of an interesting situation because I think a lot of healthcare providers felt differently about it, but I was 7 months pregnant when everything shut down in March of 2020, and it was terrifying. I didn't know if I was risking my family, Anything can happen in the ER. You can get punched or kicked or strangled, which is awful and shouldn't happen. But you also don't expect to just be, over days, weeks, months, years, exposed to something dangerous. And especially at the beginning, we didn't totally know how dangerous. And a lot of healthcare workers who were otherwise healthy did die. Obviously, that wasn't a majority, but it was really scary. And to have that just kind of overwhelming pressure on top of all this other stuff that doesn't work as well, that was really unique and pretty rough.
I was still working in the emergency department during the pandemic. My kids, they weren't super little at the time, elementary school and middle school age. Everything was on shutdown and everybody else had these study pods, but people were afraid to be around us.
Yeah.
Nobody wanted to be around my kids. And on top of the fact that no one wanted to be around my kids because of me, because of the exposure risk, I was actually working outside of the home, whereas everybody else was home with their kids. So it was really a hard time for our family, just trying to navigate all of that. And we train our whole life to perform in the moment when society needs us. And so I felt a lot of conviction about desire to serve in that moment. And at the same time, what am I sacrificing at home and how is that impacting my family? It's always been constantly that pull. How do I do the right thing and make sure that my skill set that I've been blessed to be given doesn't go to waste, and at the same time balance that with what my family needs?
Dr. Bourne's emergency medicine group has thus far been able to remain independent, affording her and the other partners the flexibility to take care of patients without the same administrative micromanaging many of our residency colleagues now experience. It also means there is more autonomy for the group to organize itself in a way that is supportive of its members and their lives outside of the hospital.
I do have a unique job in that we're a small group. It's one hospital, and we really try to emphasize work-life balance, specifically in scheduling. And so we're constantly surveying the group to see, is this how many shifts a month that you want? Do you want to try to step up? Are you wanting to step back? And I think the pattern has been most of us have stepped back, sometimes significantly over a period of years, and we just staff up because of that. So I think that's been great. But I mean, on the other side, I'm an independent contractor. The time that I wasn't working, I got zero money. So for my first child, I took off 8 weeks. And for my second one, I took off 12, and that's including before he was born. So I think I went back when he was 6 or 7 weeks old, and my husband played mom harder than most dads ever do as far as feeding at night and waking up and all that stuff, heating up breast milk. So I guess we tried to create something that is supportive within our domain. And I'll say that I work in a very dying breed of ER groups, which is independently owned and not corporate. And so it's owned and run by the physicians who work it, which is getting more and more rare as corporate medicine is buying groups like mine up.
Why do you think that is? Do you have insight into why corporate groups are buying up more and more emergency physician groups?
I mean, it's obviously about the money, and they're able to kind of shift and undercut salaries somewhere while they're pushing for more with more negotiating power somewhere else. And because of the complexities of the reimbursement in medicine, it's generated this entire other beast. In healthcare, a minority of the people working are clinical. And so there's this tip of the iceberg where under the water, there's this huge administrative burden to do and get paid and follow the regulations for what we're trying to do. And so it's just multiplying and costing more and more and more. So if you're big, you can, I think you've mentioned before, economy of scale, like you can handle that administrative burden and potentially at least bid a service for lower than some of the smaller groups like us.
Now in the United States, more than half of physicians are employees of large health systems, as more and more private practices cave under market pressures, selling to large corporations. Inability to negotiate higher payments from insurance companies and the cost of managing increased administrative tasks were the top two reasons cited by physicians when asked why they sold their practices to large corporations. Meanwhile, up to 30% of healthcare costs are attributable to administrative tasks, which include things such as billing, insurance requirements, and quality reporting. Studies have shown that the U.S. spends over $1,000 per person per year on administrative healthcare costs. That is 3 times the amount of the country with the second highest administrative burden. We feel the pain of that in our primary care practice for sure. It helps to have that economy of scale. And so for us, we really feel like in order to survive in the current economy where there's so much consolidation going on and the market dynamics don't support independent primary care practices or even independent emergency physician practices like you're describing, unless we can figure out how to grow, that is the only way that we're going to make it. Because we keep dealing with Medicare cuts, we keep dealing with inflation, the rising cost of labor, all of these things that are squeezing us. And the only way to mitigate that is to get bigger. It's tough, and I think that the downside of that, especially in primary care, but probably to some extent, even in an emergency medicine group, is that then the physicians lose autonomy if they're being acquired by these big corporate entities. And we lose decision-making power. And that trickles down to the way we care for patients because we're no longer in the driver's seat.
Yeah, and that's, simply put, that's dangerous, We need to be able to do what we think is right with the experience and training we have and not be told what we can and can't. And I think that's something that frustrates a lot of my colleagues is to have a lot of non-clinical burden and then to be micromanaged. So I'm thankful we're able to keep our group, and for all intensive purposes, we're doing well, mostly because it's so difficult to recruit where we are, which is a problem everywhere. But we have really strong community ties, and you'd have to pay someone crazy locums fees to come and take over. So we both struggle with that to staff, and we're also protected by that, I guess.
Despite all the challenges, Dr. Bourne has found ways to stay inspired. One of her new passions comes from the work she does with the Mammoth Mountain Ski Patrol, where she finds examples of teamwork and camaraderie that abound despite the austere environment of snowy mountain terrain where the stakes are often high.
One interesting thing that's come up in my career recently is that I'm a medical advisor of our local ski patrol. And it's been really interesting to see their dynamic. I mean, they literally ride snowcats and snowmobiles and throw bombs and shoot cannons. We have a howitzer from the Second World War, I think. Maybe the First World. It's crazy. But they have this wild job that covers everything. But they're definitely a team. They have training. There's kind of a lot of institutional knowledge, and ours is really progressive. There's a lot of women. I think they're forward-minded, but just to kind of experience this other situation in which there is even a hierarchy, but within that, there's a lot of community. It's something that's fun to see and experience, even just on the periphery. And that's something that kind of excites me. Also, I'm a passionate skier, so to be able to move around on the mountain and see what they do, and I'm just so impressed with them. They work in such a challenging environment with limited tools, and I do case review. I know they've saved a lot of lives. It's really wild. I have a little bit of a crush on that specialty. I'm not gonna retrain. But I think a lot of us in medicine are, I would say, like eccentric, but it's good to have something else and having that be kind of like an anti-burnout, increased resilience type of thing. Before this conversation, you were talking about some of the artistic endeavors that you have, and I think it's important to find the things that fill your cup, because we can't depend on medicine to do that, even though we went into it to help people. And sometimes we get that, but we definitely can't depend on it. Not now. Medicine doesn't permit weakness. You know, I think in the training and the build-up to becoming a physician, that's not acceptable. It's almost not part of the vocabulary. More recently, I've now have a therapist and a psychiatrist, and I take medications, and it was like this huge journey for me to even go down that path, even though I was suffering. And in retrospect, it was so crazy, because it was like, how many people have I seen in the ER with what seemed like a panic attack that, you know, I go through the rest of the workup. But then I think for myself, it was months later where I was like, I think that might have been a panic attack. Like I couldn't even, I like didn't even know how to apply it to myself, you know? And so I hope they're doing a better job now through training, recognizing that we're still human. But I feel like in addition to our specialty, you know, expecting more, we're supposed to be above the pain and the illness and the weakness and any mental distress. And I think that's not achievable, you know? It's not realistic to expect that of us. I think that's been perpetuated through the generations of physicians, but can be harmful.
Dr. Bourne's ski patrol colleagues have demonstrated a better way to cope with work-related tragedy. Not long ago, the terrible loss of a patrol member, a young woman performing avalanche control, left the community reeling.
I've seen them experience loss this year and how they rally around that. And it's been interesting because it reminds me of other situations in which there's been more of just family-like support. The biggest simple thing without, you know, rebuilding our healthcare system and fixing the EHR and, I don't know, AI writing all my notes. The thing that I felt was within my control was trying to build the relationships between providers and your team and all of that, because that builds resilience. Building positive relationships and caring about each other and having that rapport can be contagious in the positive way. So I think that's something that I've tried to do on the level of chief of staff, to the extent of creating a program for provider socials where we just get together outside of the hospital and can share some time and life stories.
Not only has Dr. Bourne created schedule flexibility to accommodate work-life balance for the doctors in her group, But she has also paved the way for doctors that work at her hospital to feel comfortable speaking up if they need help with mental health. When hospitals credential physicians, often the questionnaire requires disclosure of prior mental illness as part of the criteria for determining if a physician will be allowed hospital privileges. Statistics show these questions actually prevent doctors from getting help and increase the risk of suicide.
As Chief of Staff, we just reorganized our credentialing for allowing physicians or providers to do what they do at our hospital. And we reworded it in alignment with the Lorna Breen Foundation that was created from the ER physician who committed suicide in New York in the peak of the pandemic. So it's interesting to see even those effects coming down to the policies that I'm signing now. So, things are happening, if not on a small scale. Unfortunately, I think that's how our society works, is that sometimes something big and bad has to happen in order for us to adjust, but that's maybe like a lot of things.
It can feel so overwhelming and we can feel so overburdened, but nothing can change the fact that the work is still meaningful. And even in these darker times that we're in our field, where there's so much that's put on us that isn't really about taking care of people, we still have to hold on to that inspiration and passion that keeps us showing up to work, and not just showing up, but showing up with that energy that we can transfer to others so that other people feel lifted up.
I still believe in what we do. I think it would be nice if there were a more unified and sensical way to fight for what's right and what should be done. And I think some of our ER organizations are working towards that, and we can potentially enact some change, but sometimes it just feels too overwhelming too. So I think it's important, again, like you said, to find the inspiration and bring it full circle. Try to bring it, generate it, share it, rinse, repeat.
If you or a loved one need mental health support, free help is available thanks to the National Suicide and Crisis Lifeline. Dial 988 to reach a counselor 24 hours a day, 7 days a week. That's 988 to get immediate mental health support. Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare in America through conversation. If you liked what you heard today, please follow this podcast or find me on Instagram at drjoymd. That's DOCTOR Joy MD.